we have to now talk about something else, and that is pain associated with MSE. I know I said that was my last question before, but this is a really big one, because most of what people know about MSE pain comes from what I've said about it, which is on the extreme. I had a lot of pain when I had my cortical puncture, and when I was turning several turns a day initially to split the suture. I had a lot of pain, and I was very public about how painful it was. Probably when people are hearing you say about the doctor chiseling through the suture and then cutting this bone, they're thinking, oh my gosh, that's insane. I'd rather keep my small airway and my small face than go through all that. What do your patients tell you about what it's like to do a surgical assist with Dr. Vaughn, and or even just a cortical puncture with you, or even just an MSE install, the 4 TADs?
Excellent. So let's do step by step.
Okay.
First, let's talk about the MSE alone. Now, MSE alone, the insertion process is very, very important. Okay. Now, if this adult patient does not have anything else, just do MSE alone. If you talk to a grown adult person, most of them will tell you they don't have a lot of pain. They have some minor discomfort that Tylenol can take care of it. Sometimes they need to take Motrin. Okay, now that's what a responsible adult usually give answer to us. When you ask teenager, it's a complete different story. Teenager are different animals. Teenager will make the parents call us. I have excruciating pain. I have this. I have that. I'm dying. But does teenager blame the parents for making them have MSE? That's in my personal opinion. I never have a grown, responsible adult ever tell me that I'm dying with the MSE. Okay. I have one or maybe two ladies calling us. I have pain, what should I do? I have this, what should I do? But after they calm down 2 weeks later, 3 weeks when I do my check, they will say, yeah, pain was a little bit intense only the first day, and afterwards, actually painkiller took care of it. Okay. I think more worry, for adults, more of a worry, they feel something funny, there's something I need to worry about, than a physical pain in my office. For teenager, you can trust them because they blame parents for everything. They want the parents to feel bad. On young kids, however, they have no pain. Our young kids didn't take painkillers. I have a lot of testimonial on my YouTube video. If you search my office website, we'll link to my office YouTube channel. Their kids talk about they have no pain. Okay, now, why is my MSE experience so much different than your MSE experience? There's one simple fact. I do not do fast turn protocol. Okay, my protocol is either don't turn the first day, or if you have to, okay, then we do 1 turn a day. Okay, 1 turn a day simply solve a lot of those severe pain issues that you associate with the TAD dragging in your bone, tipping the thing and stretching the tissue and feel like your skull gonna split. Basically, take care of all those problems. And
so
also,
I'm sorry, Dr. Ting. So when you say 1 turn a day, you're saying that you instruct your patients to turn their, because of course the MSE is an appliance that the patient turns. The patient has a key, the MSE has a little hex screw, and the patient turns it him or herself. You instruct the patient to turn 1 turn per day.
1 turn a day.
Until finished, from start to end, 1 turn per day.
Yes. Now, I also instruct patients when you hit resistance, when you have a hard time turning, don't turn. Wait for a few days. Wait 1 day, 2 days, 3 days, no matter what, okay, until it's easy to turn again. Okay, because the bone needs some time to remodel and split. If you force it, guess what will happen? You increase a lot of pain, unnecessarily. At the same time, you're actually tipping the MSE screw. If the bone's not going to give, what's going to give?
The MSE.
The MSE. So the TAD start bending. Okay. One of my reason my MSE's failure rate is only 1%. It's all my failure have is follow the one fast protocol. Okay. Again,
I did that. That's what I did, and it was painful. It's all hell.
It's an orthodontic genius. Okay. Fasting protocol totally worked for MSE1, but MSE2 is a complete different animal, but he followed the same protocol. From my experience, once you start doing the fast turning, force turning, the first thing you do is your MSE will start bending. Now you have tons of space waste, okay? Because your screw tip, so now you lost 2 millimeters here, lost 2 millimeters there, you have 4 millimeter expansion potential completely wasted, or maybe even 6. Okay. Secondly is once you bend, the whole MSE start warping. Okay. Once they warp, okay, think about it this way. This is the MSE, then that's the arms. Okay. And once the MSE start warping, the arm starts sticking outward, digging into palate. At the same time, push your molar out.
Mm-hmm.
So a lot of pains from molar bending outward.
Oh, wow. That sounds dangerous, actually.
So it is, it causes bone dehiscence, and then that's why a lot of problem happens. So if you use slow turning protocol, all those will be prevented. You don't have to turn that fast. Why? Because my success prove it, fast turning protocol is not necessary.
Yeah.
Okay.
Yeah.
All my failed patients is from those protocol. At the same time, you have flexing of the MSE, so the arm starts sticking sideways and start flexing out the molar. You have so much molar pain. My wife is one of the failed cases. She's one of the early young MSE2 cases I have. Her case totally failed because the whole thing just warped the molar get tipping outward. She has severe pain in the molar every single day. She's like you, miserable.
Yeah.
Okay. That's when I decided there are something wrong with this turning protocol that does not work. Until the end, when the warp so much, you can't even turn the screws anymore, or the screw will break apart. Okay?
I had a lot of those issues in my own MSE case. I did.
It's all got to do with a fast turning protocol. If you follow a protocol, a large percentage of the case will fail.
Yeah.
That's why I started, a lot of experienced MSE user start using the slow turning protocol.
And you know, the reason I remember specifically why I was allured by the fast turning protocol, because I had this idea that until I split, so first of all, there was anxiety. Is the suture going to split? Is it going to split? I wonder, am I going to be one of the lucky ones who it splits? And so I was anxious. So I wanted to turn to get the split. Secondly, I had this idea, once it splits, the pressure is going to stop and I'm going to have this release once the suture lets go. And so again, I felt, well, maybe I can just get there faster. And so these were the ideas that led me to want to turn. And so again, this is why I like the surgical install, is because you don't have to have anxiety about the split anymore. You can just do the right thing, go nice and slow, and not have to feel like you have to sprint toward the split.
Okay. So that's for normal MSE patient without any procedure. This is how I prevent from severe pain. Secondly, it's got to do with the cortical puncture. Cortical puncture procedure, there's so many different ways to do it, okay? In general, I think I set a standard of doing it. Now, Dr. Wong suggests to use the TAD to do 6 to 7 holes, turn in, turn out, turn in, turn out. Now, anyone who have TAD put in before, when I first heard that protocol, I just think, how realistic is that? First of all, TAD gets dull. After 2 or 3 times, you gotta throw away the TAD, get another TAD. Secondly, TAD is a loose screw. So if you want to do 4 to 6 to 7 of them in and turn out, first of all, they leave bigger holes. Secondly, is you have so much high chances of dropping the screw in patient's throat. Okay, it's a really unrealistic procedure that expect to be used on patient.
Time out, Dr. Ting. You're talking about doing a cortical puncture with a CAD screw, which basically it's like you're screwing into wood. You put the screw in and then you put the drill on reverse and you pull it out. And that hole is, instead of a dental drill, you're putting the CAD in and out.
Exactly. And so it's a very time-consuming, not realistic, and dangerous process. And you're only putting 6, 7 holes. So my protocol on the cortical puncture is I get a super slow speed drill, okay, and a very skinny drill, probably only half the diameter of the MSE, or maybe less. Okay, I go in completely through and through until I hit less resistance. Out, in and out, completely, about 1 to ½ millimeter apart on every single.
1 millimeter apart?
Yes.
That's very close together.
Very close together, okay. But it's a much smaller, finer drill with a much slower speed, so we have less bone damage. Okay, hardly any bleeding, and then we'll go in and out, and through and through. Okay, that means I drill until I hit less resistance. Okay.
So what are you going through there? You're going through multiple layers of bone, and you know exactly what you're trying to do?
Going through a second cortical layer of bone. So I found out that technique is much useful because the drill is attached to the slow speed, not slow speed handpiece. It's a slower speed handpiece, the same speed as putting the dental implant, those kind of. So we'll go in and out, in and out, in and out. Those will minimize the wound, maximize chances because we extend it all the way, okay? Very little bleeding, and basically very safe procedure without worrying about anything dropping patient's throat. Now, there are some other doctors out there like to use high speed. High speed is actually, in my opinion, quite dangerous. High speed drill the drill teeth. They go in like this. Okay. First of all, they just touch the superficial bone. It's not going to work that way. So they do a little bit. At the same time, they don't go through both layer bones, okay? And then you don't have, because all the spray, the water, the bleeds, and then the high speed tend to burn the bone around the area. So will interfere with bone healing, okay? That's another way I think is not a good way to do, okay? Now, or like you say, Dr. New was there for you, they fan out a little bit. I think it's a little bit excessive. It worked, obviously. But I think the excessiveness of those processes also increased the pain.
I had a lot of pain after my cortical puncture, a lot.
So the cortical puncture we do is, the minute I stop drilling, your bleeding basically stopped. Okay, the bleeding, I love to show patients how much bleeding they have on a piece of gauze. I say, this is less than the last bleeding than the last pimple that you pop. Okay. So that's how we go in and out. So healing is super fast. The next day, they're healed. They say the holes are gone next week because we use a very, very tiny drill to drill between all lines. So that's how I enhance my cortical puncture. I think I have the record of the oldest male being expanded with cortical puncture. The oldest male I've been expanded is 48 years old.
Wow.
I don't think anyone with a simple cortical puncture be expanded on male patient. Okay.
Wow, good for you.
46 and then also a 45-year-old being expanded. So that's excellent result, and then with the minimum discomfort. Okay.
Sure.
Now, surgical assist, according to my patient, I have patient that took 1 day off. Well, after the surgery, took 1 day off. The day after, he went back to work. Okay. So they say they need to be on painkiller for 2 days. Okay. One patient say was on painkiller for 3 days, and that's about it.
Okay. So similar to like maybe wisdom teeth extraction.
Exactly. That's what they say. No worse than wisdom tooth extractions.
And so tell me about.
Usually it's 2 weeks after. That's when all the inflammation will go away.
So the inflammation peaks sooner with surgical install than with.
Inflammation probably peaked the second day.
Okay. And tell me about the sedation with surgical install. Is it local anesthetic or is it? It's not general anesthesia.
Not general. It's not in the office, so it's not general. So it's same as taking out wisdom tooth.
Okay.
It's in office sedation.
Okay, so you're you're awake, but what's it like? You're awake, but you're loopy, or are you asleep, or what?
You're not awake. You're semi-awake.
Okay.
Some people, I would say, some people are responsive.
Is it like laughing gas, where you come out of it and you say funny things?
It's not laughing gas. It's a sedation. It's an injection through your vein.
Okay, but it's not painful. It's not like it's not like you're watching the dentist, chisel through your jaw.
No.
Okay.
No. So if anybody have wisdom tooth extraction, they can sense that.
Yeah. I did mine a long time ago. I don't remember being awake for the procedure, but I also remember that I wasn't put to sleep either. It wasn't bad. I remember going to school the next day after my wisdom teeth were out. So that doesn't sound too bad. And how much cost roughly, plus or minus $1,000 or $2,000 does a surgical?
I would say around $2,000 range, could be a little bit higher. That's what I was told by my patient. Okay. So it depends on different cases, I guess.
Okay, so you can expect that if you want to do a surgical install, to pay maybe $2,000 to $3,000 more.
Yes. I'll say that would sound reasonable.
On top of your MSE orthodontist bill.
Yes. Now I have a patient, a virtual consultation patient. They say they got called for surgical assist by an oral surgeon for $20,000 or $12,000. I forgot. And that's definitely not a legitimate number. If you see a number like that, that means the surgeon probably had never done it before. They just guesstimate, give you a number in case.
Yeah, so this is because anytime you involve an orthodontic surgeon, it's scary because now the cost of dealing with an oral surgeon is an order of magnitude more than dealing with any other type of dentist usually. But you're saying you work with a guy, Dr. Vaughn, who you have a relationship with. He does this routinely. He has a more or less a fixed price that's very reasonable. That's so important to have a team like that who work together.
And talk about reasonable. It's way more reasonable than AGA and DNA.
Oh my gosh. Stop it. Don't get me going again on that, please. I was just starting to calm down.
Way more reasonable than that.
Well, I mean, look, how much I've been saying recently, AGA is a really expensive extraction procedure. I was saying if you want to pull teeth, you can do it for a lot less than $15,000. Maybe that's too harsh.
But that's not the end of the AGA because you're going to need 4 implants afterwards.
Then you're going to need 4 implants. I know.
That's $12,000 additional to it.
It's so sad, Dr. Ting, and I hate to beat a dead
$16,000 addition to it.
How much?
$16,000 addition.
What, like 4,000 a piece, 4,000 an implant? And this is the terrifying thing. I know someone, a woman who has a failed AGA case. She had so much bone loss around her front teeth that they're not even sure that they're going to be able to put implants. She has to have extractions, but they're not even sure they're going to be able to put implants after. That's how severe the damage is.